Kalorama, a recorded books hybrid imprint, presents The Long Fix, Solving America's Healthcare Crisis with Strategies That Work for Everyone, by Vivian Lee. Read by Charles Constant. Chapter 1. A Revolution of Common Sense. It was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. It was the epoch of belief, it was the epoch of incredulity. Charles Dickens, A Tale of Two Cities. The rumbling engine of the wood-paneled station wagon cut through the scorching Oklahoma summer heat as it pulled over to the curb. The radio, tuned as always to the local country station, blared Loretta Lynn's latest hit. As I slipped into the front seat, Hal Belknap leaned forward in the driver's seat to turn it down and shot me an apologetic look, as he always did. Dr. Belknap, we all called him Dr. B, was a prominent internal medicine doctor in Norman, Oklahoma. In 1979, he had volunteered for a program that matched junior high students with community leaders, and I got lucky. For the next few years, I spent my Saturday mornings at Norman Regional Hospital, tagging along as he made his rounds and feeling rather like an extra on Marcus Welby, M.D., that popular TV show from the 1970s. On a typical morning, we would set out to find Mabel, Fred, Hank, Rosetta, and the other patients propped up in their hospital beds, eagerly awaiting us. Well, mostly eagerly awaiting Dr. B. After swinging their breakfast trays to the side, careful not to spill the small cartons of milk and bowls of cereal and canned fruit medley, Dr. B would sit on the side of their beds and listen to their hearts, their lungs, and their stories. He was always deeply attentive to their medical ailments, but he also wanted to find out what was on their minds. I could see him making mental notes as he asked after their families. The granddaughter's wedding. Note, have Vicky, his nurse, send a card. The husband who had just been discharged from the hospital. Note, set up home nursing visits. And the son who was moving back home. Note, invite grandson to join Dr. B's Boy Scout troop. After completing rounds, Dr. B scrawled his practically indecipherable notes in their charts, gave instructions to the nurses, and occasionally ordered a study or lab test. A naturally sharp diagnostician, he didn't request many studies or interventions, relying mostly on his intuition and judgment. He placed the most weight on what was best for the patient, and often reminded me that less was more, even in medicine. Caring for patients back then was less complicated, less bureaucratic, less expensive. Dr. B and his colleagues kept all their medical records on paper and carried tone-only pagers, no screens. CT, computed tomography, or CAT scans were new, and MRI, magnetic resonance imaging, my future specialty, had not yet come into the picture. Drug prices were reasonable and rarely made the news. But not everything was better when it was simpler. Most patients who had strokes and heart attacks died or were debilitated by them. We hadn't imagined gene therapies or robotic surgeries or electronic medical records. I also never heard the words healthcare reform. I decided back then that I wanted to be a doctor. I was certain that Dr. B had improved the lives of his patients and that it was rewarding for him, too. I set off in pursuit of this noble profession with a determined optimism. The journey to MD and CEO. 15 years later, after college, graduate school, medical school, a surgical internship, radiology residency, and a fellowship in MRI, I emerged in 1998 ready for my first real job. Finally, my parents said. In the 2 decades since I had accompanied Dr. B, medicine had changed dramatically. For one, my field, magnetic resonance imaging, had been invented. MRI radiologists were spotting small cancers early enough to save patients' lives and sparing others from the poking and prodding of procedures such as angiograms, cholangiograms, and fistulograms. New medications like clot-busting drugs were saving patients with heart attacks and strokes, and deaths due to cancer were finally starting to decline, thanks to better prevention and new chemotherapies. As a researcher and later as chief scientific officer at NYU Langone Medical Center in New York, I could see that the discoveries coming out of the research laboratories, genomics, stem cell therapy, immunotherapy, the microbiome, and more, were offering new hope for many, even the possibility of curing the incurable. At the same time, healthcare was also showing signs of changing for the worse. Doctoring involved a lot more negotiating with insurance companies than sitting at the bedside or thinking through hard-to-diagnose conditions. A series of widely cited reports from the Institute of Medicine, now the National Academy of Medicine, cast a deeply critical eye on safety and quality in the American health system. All the while, health costs were increasing so rapidly that it became clear that if we didn't reduce the cost of care and get our system back on track, all those scientific advances might be for naught. These realizations were weighing heavily on me when I made a visit to Boston in 2010 that changed the trajectory of my career. I went to see an old friend of mine, Greg Meyer, an internal medicine physician who at the time was the senior vice president for quality and safety at the Massachusetts General Hospital. I was there to learn about research administration from a hospital famous for its scientific excellence. While there, Greg introduced me to their sophisticated electronic health record system. He told me how it was completely changing the way his hospital was approaching care. When patients turned 50, for example, the computers automatically offered them a pamphlet or DVD, the latest technology then, that explained why they should undergo a colonoscopy to screen for colon cancer. No more relying on doctors to remember. For each doctor, the computer system also tracked which of their patients with high blood pressure were getting better with treatment and which needed more attention. Instead of getting paid for every procedure or exam clinicians performed, the hospital proposed that it should get paid for keeping patients healthy. This could include making sure they had undergone colon cancer screening and effectively lowering blood pressure in patients with hypertension. The insurers agreed. Before long, thanks to its exceptional electronic records, the Massachusetts General Hospital successfully achieved its targets. Hypertensive patients had lower blood pressure, and the hospital was rewarded with higher payments. It was a win-win. For me, this was an epiphany. With the right tools, leaders could reinvent healthcare and create a system where everyone would be paid to deliver better care. I wanted to help build that future. During that visit to Boston, Greg also unexpectedly introduced me to healthcare in a state I knew little about, Utah. He gave me a book written by his colleague, physician and Harvard Business School professor Richard Bomer, called Designing Care. It featured Intermountain Healthcare, the eminent Salt Lake City-based hospital system that had similarly used its electronic health system to achieve superior care. Utah suddenly seemed to be everywhere. That year, according to the national rankings of university hospitals, NYU had been ranked number 10 in quality and safety, while the University of Utah ranked number 1. When I got back to NYU, I tried to persuade my colleagues to make a field trip to Utah. As if on cue, an executive search firm rang up, asking if I might like to visit Salt Lake City. The University of Utah was looking for a new leader of its health system and academic health sciences campus. I got my trip out west and a new job to boot. The front lines. In July 2011, I began my new role as CEO of University of Utah Health, a health system that serves a large swath of the western United States, Utah, Idaho, Wyoming, Montana, western Colorado, and also parts of Nevada. By the end of my 6 years there, we had grown into a $3.6 billion system that included 4 hospitals, 12 neighborhood health centers, numerous specialty clinics like cancer, dialysis, and urgent care, and an affiliate hospital network of over 18 hospitals in the region. We employed over 1,400 board-certified physicians and had 1.7 million patient visits per year. We also owned and operated a national reference laboratory company, where each day tens of thousands of specimens were sent to us for blood analyses, genetic studies, and other tests. University of Utah Health was recognized for its healthcare system innovations that enabled higher quality care at lower costs, with higher patient and employee satisfaction. In 2016, the hospital was again ranked number 1 in the nation in quality and safety among all university hospitals. As CEO, I was also responsible for over 15,000 employees and trainees. We ran our own health plan, we were self-insured, to manage our employees' health benefits and those of many of the state's Medicaid beneficiaries. We transformed the plan into a commercial health insurance company to take care of the health benefits programs of other employers in our community and region. Part of the CEO job entailed serving as the university's medical school dean and senior vice president. I oversaw scientific research and the training of the future workforce in medicine, nursing, pharmacy, dentistry, and allied health professionals. The vibrant academic enterprise gave us even more opportunities to innovate. We taught our students to work on interdisciplinary teams, connected patients with rare and undiagnosed diseases to genetic scientists, worked with our engineering colleagues to establish an innovation center that included video games and apps for health, and learned valuable management lessons from our business school colleagues. Over the course of these and other experiences, I have gained a deep understanding of the complexity of the U.S. healthcare system, its great challenges and wealth of opportunities, and I have emerged profoundly optimistic that, as a nation, we can provide affordable and high-quality healthcare for all. But what exactly are those challenges and opportunities, and what is the basis for that optimism? The maddening paradox. By a few measures, the U.S. healthcare system is one of the best in the world, and by some measures, it is one of the worst. The United States leads the world in medical innovation, and its scientists are discovering new cures at an exhilarating pace. Patients with leukemia are being treated with their own immune cells engineered to attack cancer cells. Cardiologists can replace the heart's aortic valve using catheters placed through arteries in the leg without opening the chest. Patients with chronic hepatitis C can now be cured. At the same time, some of the most ordinary but vital care isn't being received. For example, 46% of U.S. adults have high blood pressure, which is a risk factor for heart attack, stroke, and even dementia. But half of those affected aren't taking the life-saving pills that can cost just 10 cents per day. Hands down, the United States spends more on health care per capita than any other nation. Nearly 1/5 of the U.S. economy goes to pay for health. That's 2 to 3 times more than other high-income Organization for Economic Cooperation and Development, or OECD, nations like the UK, Canada, Germany, Japan, and Australia, where health coverage is universal. Despite this, about 1 in 11 Americans don't have health insurance and can't afford care. Cutting-edge operations and advanced treatments developed in America provide hope to patients all over the world, but here at home we face an epidemic of diseases of despair. In 2017, while we performed 34,768 life-saving organ transplants, we lost more than 47,600 people to opioid overdoses and another 47,174 to suicide. As a result, while most of the rest of the world is getting healthier and living longer, life expectancy in the United States is declining. Babies born in the United States in 2017 are expected to live 78.6 years, 5.6 years less than those born in Japan, which places us 26th out of 35 OECD nations in life expectancy. The prospects for a healthier future are rapidly fading. 4 out of 10 adults are obese, and 7 out of 10 are overweight, making them much more likely to suffer from back and joint pain and, over time, to be stricken by heart disease, stroke, type 2 diabetes, and certain types of cancer. The highest prevalence of mental health problems is among young adults. Our failing health jeopardizes our national security. As of 2014, the Pentagon estimated that 7 out of 10 young adults in the United States would not qualify for military service, the most common reason being their weight. The nation is paying dearly for these failures. Companies that cover employee health insurance have seen rising costs that erode their margins and hobble competitiveness. Much of that ever-rising expense has been passed on to employees, often in hidden ways like flat wages over the past 50 years. Workers are also getting hurt directly, as deductibles and co-payments soar. There is one more insidious hidden cost. Since World War II, employee and employer premiums are exempt from income and payroll tax. They aren't a taxable benefit the way a bonus is, which means that the government forgoes billions in tax revenue, $275 billion in 2016 alone. Taxpayers, of course, make up the difference. Healthcare is bankrupting the uninsured and the swelling ranks of the underinsured, and it's often disappointing the millions who do have coverage. This ailing, failing system is making our nation sick, financially, emotionally, and physically. But within the seemingly barren healthcare crisis is not a spring, but practically an ocean of opportunity. We pay more for less. With healthcare spending rapidly approaching $4 trillion per year, the obvious but misguided solution would be to reduce expenses by cutting care. But that's dangerous for patients and for our future. It's not care that needs to be cut, it's the wasteful spending that doesn't contribute to better health. We have to stop paying more to get less. Here are a few of the opportunities most of us in healthcare agree on. We waste. The Institute of Medicine, now National Academy of Medicine, estimated in 2012 that we waste 30 cents of every dollar we spend on healthcare. That's over $1 trillion per year. Some of the waste is fraud and abuse, but most of it comes from failure to care for patients properly. We overtreat. A substantial part of the waste is driven by overdiagnosis and overtreatment. In a 2016 survey, U.S. physicians thought that about 20% of all medical care was unnecessary. We make deadly mistakes. Medical errors are the third leading cause of death in the United States, over 250,000 deaths each year. That's about 9.5% of all deaths, behind only heart disease and cancer. We practice medicine inconsistently. Clinicians make decisions without being fully informed about the latest science and without information about costs to the patient and overall. Physicians follow recommended guidelines only 1/2 to 2/3 of the time. We are choking on bureaucracy. In the United States, about 8% of spending on health care is spent on administration. Among 10 high-income OECD nations, the figure averaged only 3%. Healthcare professionals are paid generously but waste a lot of time. The average U.S. generalist physician makes about $218,000. Specialists average $316,000. These expensive professionals waste a large percentage of their time on frustrating administrative tasks like computer data entry and disputing with insurance companies instead of caring for patients. We push expensive new technologies and treatments, even if they aren't any better than cheaper or generic alternatives. We spend double to triple what Canada and some European countries do on pharmaceuticals, mostly due to high cost, branded drugs and the overprescription of antibiotics and other medications. We wait until it's too late. About 8.5% of the U.S. population is uninsured, and more are foregoing preventive and primary care because they are underinsured. By the time the health system sees them, we've missed our chance at prevention. We wish patients would enjoy healthier diets and more exercise, but we can't seem to influence them to change their behaviors. As a nation, we seem to favor sugar and high-fructose corn syrup-laden sweets and drinks, spending $4 billion on them annually, deep-fried food, $200 billion for fast food, tobacco, $130 billion, and sedentary lifestyles with plenty of screen time and video gaming, $43 billion, over healthier alternatives. 8-minute clinic visits aren't long enough for primary care providers to have meaningful conversations to influence these habits. We deny the wishes of the dying. We put people in hospitals who would be better off at home. In the hospital, we attach them to costly life support systems even when they have asked to be left alone. While 4 out of 5 people would prefer to die at home, only 1 out of 5 does. Most people still die in a hospital or nursing home. We are spending plenty, but not always in the right ways and without getting what we want or what patients deserve. The price of paying for action. The root cause of this crisis is the fee-for-service system. We pay for each pill, echocardiogram, laboratory test, or operation, regardless of whether it makes people healthier. Our system rewards action, not better health outcomes. It encourages overtreatment and specialty care at the expense of prevention and primary care. For example, every headache or backache warrants an MRI in a fee-for-service world, and every episode of chest pain, even if it's just indigestion, justifies a coronary angiogram. This is the fundamental flaw of American health care. It started harmlessly enough. When Medicare began in 1965, it simply paid all bills that hospitals submitted for procedures, tests, and operations. The more bills they sent to Medicare, the more money hospitals received. Over time, the industry developed what economists refer to as a supply-driven demand economy. In other words, to make money, every hospital or clinic filled its beds and loaded its patients up with tests, prescriptions, and consultations. Over the next few decades, the skylines of most urban centers were blotted by construction cranes for new hospital towers, imaging offices, and cancer centers, all of which were quickly filled with patients. Between 1967 and 1983, annual Medicare payments to hospitals shot up from $3 billion to $37 billion. By 2018, the figure was a stunning $308 billion. In hindsight, the results were predictable. When people are paid for doing something, regardless of whether it works, we tend to do more and more of it. As C.C. Connolly, the former Washington Post journalist turned president, CEO of the Alliance for Community Health Plans, put it, "If you told me when I was a reporter that I was going to be paid by the word, my stories would have been a lot longer, but not necessarily better." The pay-for-action, or fee-for-service system, motivates hospitals and doctors to do things to people, and not necessarily to make them healthier. That's backward and dangerous. Demanding results, not action. Even those of us succeeding in the current fee-for-service model realize that paying for results, better health outcomes at lower costs, would radically improve our system. If our nation stopped expecting quick fixes, a prescription, a referral to a specialist, an MRI, an operation, and instead put a premium on measurably improving lives for good, then prevention would become paramount. The medical world would focus on diet, sleep, and fitness. We would make restoring mental health as important as restoring physical health. We'd try to prescribe only drugs that work and that do so cost-effectively. We'd recommend imaging studies or operations shown to be beneficial. Back operations, for example, would be reserved for the few who truly needed them, and everyone else would be told to rest or undergo physical therapy. Hospitals and clinics would standardize care, making it safer and better, and those who didn't would go out of business. Who cares? I have insurance. If the answer is so clear, then why isn't the nation moving faster to paying for results? For one, many have a vested interest in the status quo. Maybe even more important, most of us don't really buy health care, we buy health insurance. That means we don't pay for health care directly, we pay for it indirectly, and even that is often subsidized. For about half of Americans, employers pay for most of their health care. For others, health care is a government benefit paid for by taxes. Only the 8.5% of Americans who remain uninsured pay for their health care bills directly, and mostly they can't afford them. With this insurance-based model, the dynamic between insurers and doctors can put them at odds with patients' interests. Consider a hypothetical small company, say a book publishing house or a tech startup with 200 employees. The president of the company engages an insurance company to provide health insurance to her employees. Each year, that insurance company sets the annual premium rates based on predictions of how much health care her employees will need. The employer pays 70 to 80% of the premium. Her employees contribute the remaining 20 to 30% through deductibles, co-payments, or co-insurance. The insurance company then uses that pool of premiums to pay or reimburse doctors, hospitals, pharmacies, and others for the care that employees and their families receive over the year. Instead of paying premiums to the insurer, larger employers who are self-insured will set the money in reserve to pay the health bills themselves. In this arrangement, better health isn't necessarily everyone's goal. Insurers who pay doctors and hospitals for care are incentivized to spend as little as possible on a patient's health. The less they pay out, the more profit they make. Conversely, in a pay-for-action model, most doctors and hospitals are incentivized to spend as much as possible. This means patients, or more precisely their premiums, are the rope in an annual trillion-dollar tug-of-war. Doctors and hospitals pull by ordering more tests and operations. Insurers yank back by denying those services or adding restrictions like prior authorization paperwork for expensive medications and tests. When hospitals or doctors charge more than insurers are willing to pay, patients can get caught in the middle and be asked to pay the difference, leading to so-called surprise bills. Usually, we expect competition in the market to drive innovation that leads to better services at lower costs. Not so here. Because we have an insurance model of paying for health care, the normal economic rules of the market don't readily apply. For the insurance model to work, many healthy people have to enroll in a plan to offset the costs of unhealthy people. That's a great deal for those who need expensive medications or a knee replacement, but a lousy one for those who don't expect to use a lot of services. When healthy people opt out of such plans, leaving just the sicker and more expensive in the pool, premiums go up, and even the moderately healthy people are priced out. This also means that people who are insured have more incentive to get care they think they have already paid for, especially once they've spent their deductible. Use it or lose it. That drives costs up for everyone. Leonard Saltz, a doctor at Memorial Sloan Kettering Cancer Center in New York City, explained it to me this way. It's like a dozen of us go out to dinner, and we're going to split the check. You cleverly realize you might as well order the surf and turf instead of a cheeseburger because you're going to pay the same amount regardless. That works until everybody orders lobster, and all of a sudden the check is much higher. That's where we are in healthcare. When you take your child with a sore throat to the emergency room for a strep test that could be done in the clinic, undergo an MRI you probably don't need, or fill unnecessary prescriptions, say for an opioid pain medication or an antibiotic for a common cold, you, or the doctor who prescribed it, are piling on more and more surf and turf, and all of us are paying that grossly inflated dinner bill at the end of the night, which in healthcare means higher premiums for everyone next year. What are we paying for? Progress in fixing U.S. health has been held up by its daunting complexity, polarized politics, and many entrenched interests. Some argue for radical change, that the only solution is for the private insurance companies to be replaced by the federal government. Others believe in a totally free marketplace, including moving government-run programs like the Veterans Health Administration and military medicine to the private sector. Regardless of whether the payer is the government, an employer, or an insurance company, the root cause of our problem still needs addressing. It's not who runs the system that matters, it's what they pay for that needs to change radically. A tectonic shift away from fee-for-service. The good news is that things are changing. The Centers for Medicare and Medicaid Services, or CMS, are shifting away from fee-for-service to new value-based payments and alternative payment models. CMS pays for $1.3 trillion, 37% of U.S. health care. So it's like the old E.F. Hutton commercial. When CMS talks, people listen. In 2012 in Utah, we listened attentively. First, the state's Medicaid office announced that as of January 2013, it would no longer pay our hospital and clinics on a fee-for-service basis for its beneficiaries. Instead, we would receive a fixed allocation to cover care for each person for the year. The amount would be adjusted depending on the medical conditions the patient had. Within that budgeted amount, we had to meet expectations of high-quality care to keep the Medicaid contract going forward. We were going to get paid for results, not action. Second, Medicare announced it would begin the Bundled Payments for Care Improvement pilot project for total hip and knee replacements, two of the most common procedures in the United States. In this program, Medicare would pay hospitals a fixed or predefined fee to cover preparation for the operation, the surgery itself, and all the medical care necessary for 90 days after the surgery. If the patient got an infection and had to be readmitted to the hospital after the operation, it would be at the hospital's expense. If the hospital spent less than the allotted dollars, it could share in the savings. These two announcements were a shock to the system. We realized that our future success depended more on delivering better outcomes at lower costs than on how effectively we could bill for yet another MRI or yet another operation. We felt unprepared. Leading innovators. Fortunately, at the University of Utah, I led a high-performing organization that could afford to think boldly. Our innovative leaders embraced change, and we were keen to put our collective toes, as a community of clinicians, patients, and their families, and as one of the state's largest employers, into that ocean of opportunity. Like other hospitals across the country, we studied industries outside of healthcare that had spent decades competing on who could deliver better services at lower prices. We had a lot to learn. For example, in
Sample complete. Ready to continue?